Good morning, everybody. We're just waiting for everybody to join. Missy, can you tell me what it looks like? I'm not able to see.
Sure. We've got about 72 participants,
Okay.
and that's been pretty steady for the last couple of minutes. So I think we're probably
Okay,
pretty safe to
perfect.
start.
Perfect. Thank you. Well, hello, everybody, and thank you for coming today. Just to let you know, this is being recorded. We very much appreciate your interest and participation and input in this important work. I'm Kelly McPherson. I'm the State Health Information Technology Coordinator leading the work, the consent management solution work, along with my fine colleagues today. We're going to go ahead and get started. We have a lot to cover. We're going to go ahead and start with introductions. So like I said, my name is Kelly McPherson. I'm the State HIT Coordinator. I'm going to pass it over to Samantha Schrader.
Hi, everyone. I'm Samantha Schrader. I am the Data Governance Specialist focused on the electronic consent management.
Thank you, Sam. Yep.
Yeah, hi everyone. My name is Jennifer Alvisuras. I'm a Health Information Technology Program Manager, and I will provide an overview of the HCA Health IT initiatives. Linda?
And I'm Linda Reeder. I'm the Project Manager for the Electronic Consent Project. Welcome. And
Missy?
Hello, everybody. My name is Missy Sterling, and I am providing technical support as well as a couple of extra bonus options at the very end. So if you need any assistance, you'll see my message in the chat. Please send me a message if you're experiencing technical difficulties.
Wonderful. Thank you, everybody. All right. Like I said, we have a lot to cover. We're going to go ahead and get started. So Sam, I am going to pass it over to you.
Good morning, everybody. As Kelly said, we have a bunch to go over today. So I'm going to go over the agenda real quick and talk about a few logistics. Up after me will be Jennifer talking about an overview of the HCA Health initiatives. Linda will give us a recap in projects so far and where we are within the timeline. And then I'm going to talk to you guys a little bit about provider outreach for you, what things we have been doing, etc. During that time, Missy will be assisting us with a mentee. So she'll give us a full rundown of what to do with that at that time. Throughout the, feel free to enter questions into the Q&A so that we can answer those for you towards the end. And then we'll just wrap up the meeting, the quick next steps and a recap of any action items that we have. Jennifer, are you ready to go?
Yes, thank you, Sam. Hi, everyone. My name is Jennifer, and today I will be talking about the HCA Health IT initiatives. Next slide, please. One more slide. So these initiatives are interworking technologies that support better health delivery and user experience in Washington. And so HCA has embarked on, I see there's a, can everybody hear me okay? Sorry, I see there's a comment on the bottom that there was, okay. Well, sorry. So HCA has embarked on health technology infrastructure that will connect around a third of Washingtonians to more than 75 health and behavioral care and social services, allowing for more equitable access to these programs and resources. And this is important because current technology capabilities have been outpaced to provide critical health, behavioral care, and social services. And these new tech updates will better support the delivery of care, allow for statewide, secure, efficient sharing, and use of electronic health information across organizations and regions. Sorry, there's some feedback. Okay. So the purpose really of these new techs is to improve health outcomes, to improve health care equity, and to lower healthcare costs. These improvements will reduce duplications of treatment and tests and advance the care coordination across healthcare, the healthcare industry. These updates will happen over some time and will take the collaboration of many different stakeholders and various state agencies over several years. But how are we going to get this done? These updates are broken down into 9 projects that that create this infrastructure. They're depicted here as an infographic, but later on in my presentation, I will provide a high-level overview of each of them. Next slide, please. So let me talk about the overall goals. The interworking health technology updates are meant to be equitable and provide a person-focused care. That is to say that these technologies should be enablers of solutions and not barriers. The updates will provide more access to services for more people, will provide faster access to care and resources in times of crisis, and state agencies will have the ability to use the data to address inequities and improve health outcomes to better serve communities with historic barriers to care. Next slide, please. Another goal of the technology updates is to enable intuitive care and services with easier to use systems to help people connect to services and keep those services once they are on them. Really, the focus of this entire effort comes down to the ability to coordinate care across providers, programs, and services, and communities in an accurate and secure manner with increased efficiencies and reduced redundancies. Next slide, please. So what does this look like in the real world? Well, let's take this example of a single parent household with 2 children under the age of 18. The child is dependent on the parent's insurance plan and the parent relies on Medicaid and SNAP for food assistance. Say there is an issue where there is a lapse in eligibility and a child has been removed from the parent's insurance. Current obstacles that exist in the health system may be that due to an address change, the parent did not receive notification that their child would be temporarily without insurance, and the parent was not informed until a doctor's visit. Now the parent has to take off time work to make changes and updates. And although the parent has now reapplied for insurance, there is a 90-day gap in coverage. During that time, the child may not have immediate access to immunizations, behavioral health professionals, pediatricians, or the well child exam that is required for the next school year. In addition, there are multiple applications to continue Medicaid benefits for food assistance, which can be time-consuming to fill out. Future improvements to health system technology infrastructure are meant to reduce these issues. With the new infrastructure, a new change in address can be documented across systems so that the parent receives this information electronically about the upcoming lapse in a timely manner. A parent can continue a child's care via one application, which requires input of their information only one time. And the child continues to receive and be covered for vaccinations, behavioral health needs, and preventative pediatrician visits. At the same time, a parent can also be connected to other social services, which they may be eligible for. So this example highlights the need for systems to effectively communicate with each other. And in the next few slides, I will talk about the mix of systems, the underlying enabling technologies, and the strategies that will get us to this streamlined model. Next slide, please. So the first project is a process to make data acquisition and data management automatic. Making systems automatic improves data collection. It checks data for quality and uniformity. It digitizes work by using tools to streamline and centralize routine tasks. Automation also helps eliminate human error and can provide accurate demographics and data for multiple state agencies. Next slide. The next 2 projects are enabling technologies. First is the integration and interoperability layer. Integration translates data from different systems, and interoperability means that the 2 systems speak the same language. And this layer is important because we want our technologies to be able to exchange data and then use that data once they receive it. Integration and one more point in the last slide. The integration and interoperability are really the glue that allows a seamless exchange of data in this interworking system. Next slide. So next, and very closely related, is the Fast Healthcare Interoperability Resource, or FHIR. And FHIR helps systems talk to each other by standardizing data transmissions. FHIR is the current standard when managing healthcare information, which includes rules on how data can be exchanged between different computer or cloud systems, regardless of how that data is stored within those systems. Next slide. Okay, so the next few slides are on individual systems where each component has a specific topic related purpose. The first one is the Master Person Index, and MPI is a unique identifier for every person and keeps track of an individual's changing personal information across different systems. An individual is assigned a unique identifier, so they are represented only once across the organization. This is how the interworking technology keeps track of an individual across different programs for improved service delivery, client experience, and effective program coordination. Next slide. The next component is the integrated eligibility and enrollment. IIE is really where we get the one application for multiple programs. This creates streamlines a person's application and enrollment and helps them navigate the more than 75 health and human service programs to which they may be eligible. This application allows familiarity and a singular process for users. IEE is really meant to be accessible for all users and address physical and social barriers such as disability and language. Next is the Community Information Exchange. The CIE helps aid the coordination of and the connection of necessary community resources. It identifies and screens for health-related social programs, shares data, and closes referral, supporting the connection of clinical providers and community-based organizations. It assists with data analytics of health-related services, and it also supports the connectivity and coordination between social service organizations and CBOs. Next slide. The next component is the Behavioral Health Crisis Response System. This system sends out response teams to people in crisis and identifies the resource for care in the region. Dialing the 988 line connects a person to confidential free services available 24/7, 365, and connects those experiencing a mental health, substance use, or suicidal crisis with trained crisis professionals. Next slide. Next is the electronic health record. This is the project to move from paper records to electronic clinical records. An EHR shows a person's medical history, their list of current medications, ensures that the records travel with them from environment to environment, and that they receive continuation of care in a variety of health settings. And the next slide. Finally, we come to the electronic consent management, and ECM facilitates the exchange of a personal health data between authorized providers by capturing and storing consent to share sensitive information. Electronic consent management will facilitate patient authorized exchange of sensitive data while being scalable, secure, sustainable, and meets provider needs. And I believe there's one more slide. Yes. So I know that was a lot of information, but I want to stress that these 9 technology infrastructure updates will improve an individual's health experience by making the process easier for users and more connected. Each program is currently at a different implementation phase, and they all have different timelines. But for now, I will leave it there. See if my colleagues have anything else to add. If not, I will pass it on to Linda, who will discuss electronic consent management in further detail.
Thank you, Jennifer. Next slide. Good morning. I'm Linda Reeder. I'm the project manager for the Electronic Consent Management Project. And we wanted to give you an update on what we've been doing in that regard and what our timeline is, and just a little bit more detail about the solution that we're looking to deploy. So next slide. Next slide. Oh, okay, thank you. So as Jennifer was saying, the purpose of the electronic consent solution is to deploy a solution that facilitates patient authorized exchange of sensitive data, and it's scalable and secure and meets the needs of the providers and HCA and other stakeholders. And our first use case that we're looking at, the first kinds of consents that will be in the system, would be consents that would enable exchange of substance use disorder data. Ultimately, the intent is that the electronic consent solution will be a generalized consent solution to store consents for that would govern exchange of various types of sensitive data, HIV data, research data, genetic testing data, perhaps other mental health data, tribal data, other types of things as well. But we're starting with our first types of consents, which are those that govern exchange of SUD data. So next slide. So just to give you an overview of our timeline, we're currently in phase 3 of the project, and phase 1 was in 2020, where we met with various providers. We had several focus group sessions to define what the requirements would be for a consent system and to understand some of the current challenges that providers are facing. So the cohort that we met with were primarily behavioral health providers and SUD providers. And we tried to get providers with the different types of services, residential, outpatient, intensive outpatient, methadone clinics, EMS, even primary care providers that have behavioral health services, some jails. We did talk to Department of Corrections as well. So we tried hospitals, ERs. We tried to gather as big, as broad a cross section of information as we could as we were developing those requirements. And this was actually the spring of 2020, right as the pandemic was getting started. So really, really appreciate the effort. And some of you on the call here might have been part of those sessions. Really, really appreciate your effort to meet with us. They were virtual, but to make the time to help us define those requirements and kind of understand some of the workflow and the challenges. And then, so we developed our functional and our technical requirements from that. In phase 2, which was in 2021, we did put out a request for information, an RFI, out to the vendor community, and I think we got 7 or 8 responses. And basically, we're just trying to understand more about the vendor community, get some thoughts about pricing, and just gather a bit more information from their perspective that would inform the request for proposal, the RFP that we've now put out. And again, and doing just as much due diligence as we could before we did that RFP. We also did some benchmarking with some peer organizations across the country that have previous experience with some kind of electronic consent solution. So currently we're in phase 3, as shown on the diagram here, and that started in April. And we were doing some planning and getting ready for our procurement. I'll go a little bit more in detail about the RFP schedule, but we did put out an RFP last fall. We're currently finishing up that process with the vendors, and we expect in February we would be announcing a apparently successful vendor for the consent solution. We're looking to kick off the actual deployment with that vendor in May of 2023, as shown on the diagram here. And we're thinking that the system would go live. It would be about a 6-month deployment, and we're thinking it would go live in November of 2023. And obviously the vendor will have some say in that. So we will certainly have discussions and really finalize the plan once we have the vendor on board and are working on the final plan with them. And I'll talk a little bit more about the baseline solution and our expanded solution here in a minute. But we're thinking that we'll deploy a baseline solution in Q4 of this year in November. And then in 2024, would deploy an expanded solution, which would have some additional functionality, et cetera, that I'll talk about in a minute. But the timeline for that second part would be in basically calendar year 2024. So next slide. So basically our approach is to go with our baseline solution first and then have our expanded solution. So with the baseline solution, we would deploy the essential functionality to create, modify, and revoke consents, track consents. And then we would be looking for basic navigation, It would be compliant with all applicable laws, for sure. There would be some alerts and tracking, et cetera. And it would deliver value to providers in order to have a source of truth for the consents that would enable the SUD data exchange. And then because this consent solution would be considered a module, a component of the state MMIS, the state Medicaid platform, we have to go through a CMS certification process. It's pretty rigorous. And a lot of that would happen within the month or so prior to that go live in November. And that involves demonstrations, presentations, documentation that we would need to submit, talking with them about test results, that kind of thing. So we're looking to get this up and going and not try to boil the ocean all at once, trying to come out of the gate. We're trying to get this going with a solid solution, but then there's some additional things that we can add on later that we'll do in 2024. So this is our baseline solution. So next slide, please. So for the expanded solution, we're looking to build out from the baseline solution, and we would have additional use cases, and we would certainly be, again, talking with the provider community and our system users about what they would prioritize in terms of the additional use cases. So perhaps we would add consents for genetic testing data exchange, or other types of mental health data exchange, or STI data exchange, or something like that, something that requires some additional permissions to be able to exchange that data. Some additional client populations could be added, perhaps tribal members, perhaps other non-Medicaid client populations, and that's all to be determined still at this point. In terms of system access, at this point, we're thinking it would be probably a standalone portal. As we get into the expanded solution, there could be other integration with electronic health records, where the providers could not have to go into a separate portal. They could just go into their native EHR system and access the consent system that way. We are also talking with the vendors about phone applications. That's certainly an active area of development for them, and they've come a long way in the couple of years that we've been doing this work. So we may or may not have a phone application available with the baseline solution. It kind of depends on which vendor we go with. And then we would, again, be looking at interoperability with other types of systems, maybe a case management system, maybe an EHR, maybe another MPI system, that kind of thing. And perhaps, Jennifer was talking about all of the other initiatives that HCA is working on in terms of health IT to promote whole person care and more efficient services. We're really looking at this consent solution as a foundational technology that will play a role in the success of all of those other initiatives. So for example, the EHR that HCA would be providing for providers who don't currently have one, we could integrate the consent solution with that. We could utilize the consent functionality with regard to community information exchange to refer somebody for social services, or if they come to the 988 crisis line, if they do some kind of follow-up services with a behavioral health provider, there could be some consents involved in terms of exchanging records to allow efficient follow-up after that initial call to the crisis line. So we're really trying to also think big picture. We just want to get it going. And then there's a lot potential that we could do with this expanded solution in 2024, and especially as these other initiatives move forward. And as Jennifer noted, they're on different timelines now, and we'll know a little bit more later this year. And then again, we would talk with the providers and other stakeholders and partners, and obviously the vendor, about what the priorities would be for that expanded solution. So that's basically our two-step approach that we're looking at. So next slide. So the essential technology that we're looking for is something that's a cloud-based system, definitely role-based access that has tight controls over who would have access to those consents. We're looking for something that's interoperable with other systems, could be other EHR systems, other MPIs, other consent systems, maybe other case management systems, etc. And we're really looking for solutions that utilize current industry standards in terms of interoperability. And certainly that they would be compliant with all the applicable policy and security protocols. And we've made it very clear to the vendors exactly what we expect them to be in terms of compliance. And we've given them lots of detail in terms of that. And then certain operational reporting and analytics. For example, what we heard from the providers during our requirement sessions were, for example, that they would like to get some kind of alert that certain consents are coming up for expiration in the next 30 days or 60 days or whatever their preference is, so that they could then work with the clients. If it's expired, that's fine. If they need to modify it or redo the consent or something, then they know that that's coming up to be expired in the next few months, and they would have a heads up and could plan better in terms of managing those, and wouldn't have such a paper-based process like they do now. And that's what we heard from providers a lot, that they were still fairly paper-based. Some have technology, but many providers are still paper-based. So next slide. So again, the primary solution requirements would be the basic create, modify, and revoke consents, definite version history, electronic signatures, good help, interactive help, and user documentation. And then again, certain reports and interactive dashboards for both the provider users and HCA to understand the status of the consent and how many consents are being created and which ones are coming up to be expired, that kind of thing. Next slide. Oh, next slide. So as far as our procurement, this is a little bit hard to read, but basically we put out the RFP, the request for proposal, out to the vendors in October, and their written responses were due on November 23rd, right before Thanksgiving. And then we went through a process of having several reviewers from several different types of domains, looking at the functional requirements, technical people, policy folks, management, various types of staff looking at these to evaluate their written responses. And then just a couple of weeks ago, we finalized some vendor sessions where we had some of them do demonstrations and presentations to HCA, and then we're evaluating those. And we expect in February to be announcing the apparently successful vendor. And then there would be a contract negotiation process. And CMS, again, because this is considered to be a module of the Medicaid state platform, CMS would need to approve the contract as well. So we're planning on that happening by May. And then we would have a kickoff with the vendor in May for approximately 6 months. And that we would be then looking to go live in November of this year with that baseline solution. And again, once we get the vendor on board, we'll tighten up that plan, but that is what we're going with at this point. And that seems realistic, but we'll certainly get into the details with the vendor. So next slide. So just as a side note, as I'm sure most of you or all of you are aware, the Part 2 NPRM came out in November. Just for your information, HCA has convened a group to review, including the HCA privacy officer, to review the NPRM, and HCA is putting together a coordinated response, one response back to CMS, gathering all of the information from the agency and submitting that. Comments are due by January 31st, so just a few days from now. But anyway, just to let you know that HCA is making note of this, have definitely been discussing this with the vendors, and again, being very, very clear to them that they need to be compliant with all applicable laws. And a lot of the proposed changes would bring the Part 2 regulation more in sync with HIPAA and some changes that were made as a result of the coronavirus pandemic. So we are on top of that, and we are being very, very carefully evaluating any impacts to the project. So next slide. So here's just some resources and a helpful fact sheet that CMS has put out. These slides will be up on the HCA webpage that Samantha will tell you a little bit more about here in a couple of minutes. But just so you know that HCA is very much on top of this and tracking this. So next slide. So with that, I will hand it off to Samantha. Thank you.
Thank you for all of that great information, Linda. I am going to show you guys our webpage, which I think some of you have probably seen with Gov emails that have been going out. So I'm going to stop sharing my screen and then reshare it with just so that we can take a look at it together.
And there's links in the chat for what Samantha's going to show you.
Just a second, guys. Sorry, a little bit of technical difficulty. Now, I believe you all should be able to be seeing there we go. Now you all should be seeing our electronic consent management page. So this is a web page that we developed to try and keep you all up to date about the electronic consent management project and how things are going on it. So here we just have a little bit of about it, some objectives, frequently asked questions that we will be updating after this meeting and as things go on. It also has our contact information. We do have a dedicated email address that we will, I manage to ensure that if there's any questions you guys have about where we are in the project or any concerns that you're able to contact us directly. Another thing that you all may have seen in the past is the Substance Use Disorder Data Sharing Guide, which is linked here on the page. This was created by a work group here. So, reference. So if you get a chance, come take a look this over. Keep an eye on our main webpage for any updates coming out about electronic consent management. We also do try and send those Gov deliveries as those come out. I believe you'll be taking over the screen share now for us to start our Menti to get some more provider feedback.
Yep, if possible, Samantha, could you put the link to that web address in the chat for everybody too, please? All righty.
Yeah,
so
the link to the website.
Yeah, please. Thank you. All righty, so we are going to interact with Mentimeter. And for those of you that have not interacted with Mentimeter before, that is okay. This is an entirely anonymous system. So before we really get into it and learn a little bit about it or interact with it, I wanted to just share that your responses here are entirely anonymous. So we are asking for you to be completely honest with us and share that information with us to the best of your ability. I am going to place a link in the chat in just a moment. But for those of you that would like to get logged in, you can do so by accessing your internet browser. It does not matter which kind, and navigating to menti.com. It is spelled MENTI.com. When you get there, it's going to ask you for a code. The code can be found at the top of the screen. I will also put it into the chat. The link for the Mentimeter is there as well. That code that you'll need to type in is 16429857. When you get there, you will see these directions on the screen. And as you can see flying in from the bottom right-hand side, please tap the heart button on your screen so that I know that you are with me and I don't leave anybody behind. We have about 80 participants in today's meeting, so I'm looking for a number around there. Go ahead and log into menti.com. There is a link in the chat, like I mentioned. If the logging in portion becomes a barrier for you, you are more than welcome to click that link in the chat. It does direct you straight to this Mentimeter as well. Go ahead and get logged in, tap that heart button, and it's okay if you want to spam me with the heart buttons. It's not going to change my number at all, but it does make the screen a little bit pretty. So your choice. Just want to make sure we get everybody logged in. Now is the time, if you're experiencing issues getting into Mentimeter, that you let me know so that we can get you logged in appropriately. We're going to ask you a few questions here. And again, all of your responses are anonymous, so please be honest with us. I believe we'll give it another 30 or so seconds to make sure everybody can get in okay. This number is looking much better. We're going to menti.com, menti.com. We'll ask you for a code. The code can be found at the top of my screen or in the chat. And if neither one are working for you, you are welcome to hit the hyperlink that I've placed in the chat as well. It will navigate you to the same Mentimeter. Okay, let's go ahead and move into the first question. And if you're still getting logged in, that's okay. You will get caught up with us. So the first question we would like for you to answer is a multiple choice. What communication preferences do you have? And if it's not one of these three, go ahead and select the one that you have that you prefer the most of. We will ask you in just a second for other thoughts. So what communication preferences do you have? Reminding you your responses are anonymous. And you'll see the results come in real time, but again, not able to see who is answering what, just kind of where the group leans. Get another 15 or so seconds, multiple choice, you're selecting one. Okay. The next question we're going to ask you is a little bit of a free form text. And that is, do you have any other suggestions for us to consider for communication? So if one of those three options was not your preference, this is the opportunity for you to share with us your preference. Again, this is anonymous, so please let us know what that would be. We are not able to track this back to any specific individual. So what are the suggestions do you have for us to consider for communication? My screen will scroll even though we are on a full screen. So if you see what your preference is already submitted, go ahead and repeat that. The more the merrier. And if you don't have a suggestion, that is okay. See lots of nones, but also quite a few emails, so these are great. The suggestions are always good. Communicate with stakeholders via their internal meetings. Great suggestions. You another 10 or so seconds before we move on to the next question. Again, if you have questions on how Mentimeter works or you're not able to get in, please use that chat or unmute so that we can provide you the assistance you may need. Okay. The answers have slowed, so we're going to go ahead and move on to the next question. That next question is, there it goes, what existing meetings are you aware of that we can leverage to get more feedback? Again, your responses are anonymous, so please let us know what those meetings are. And if you don't have any existing meetings that maybe we can leverage, that is okay. But if you do, we're definitely curious what those are. Give you another 30 or so seconds. This is kind of one of those, either you do or you don't, but if you are aware of any meetings that we can leverage for more feedback, please let us know what those are. Fantastic. We are getting some suggestions, so this is great. We see some things like King County providers hosted, regional meetings with ASO and MCOs, monthly tribal meetings, the Washington Behavioral Health Council. All really good suggestions. We'll give you another 30 or so seconds to go ahead and think about some other meetings that we might be able to leverage for feedback before we move on to the final question.
Somebody mentioned associations. If there's a couple in particular that you would suggest, that would be helpful to name them specifically.
Yes, thank you, Linda. Absolutely. Please share as much as you are able to. Fantastic. About another 10 seconds, we'll move on to that last and final question. If you have any thoughts after the fact, I believe that our email box is open for that. All right, last and final question. Oh, well, that was lots of fun. Okay, last and final question. There it is. What are your questions and concerns being an early system user? So if you have any questions or concerns being an early system user, please let us know what those are. If you don't, that's okay. But we are curious if you have any questions or concerns on being an early system user, what those might be. So we'll leave this one open here just to think about it. We know that there are definitely some thoughts in here. So let's see, we've got some, will there be specific training to use the system? Data migration, continued training. Again, these are anonymous, so please don't hesitate to have your thoughts heard here. And as these are coming in, Linda, Kelly, or Samantha and Jennifer, if you have any thoughts around these, please feel free to unmute. Speak up. Otherwise, we're getting great suggestions already coming in.
No, this is Kelly. I think these are wonderful, and I think there's more than one, right? Ways to, I guess, even on the previous question, ways to communicate, and then these are, yeah, this is great information.
All right, I will hand it back over to Samantha and Kelly to wrap us up. This particular question I will leave open, so if you are still thinking about other suggestions, questions, or concerns that you have for us, you are welcome to submit those through the end of today's presentation. I will hand it back over to you.
Thank you, Missy. So in anticipation of that last question about concerns you guys might have around being an early system user of the electronic consent management solution we're procuring, we came up with a few answers just off of like what we thought might come up. So one of those is that there's no cost to providers or other system users. When it's going to be going live is hopefully November of 2023. We will be having training for all system users, and we have been really focusing on training and making sure that there's going to be enough training for you all with this new system that we'll be having. When we've been talking with our internal stakeholders as well as in our conversations with vendors. And then the providers will be working with HCA and the solutions vendor for staff access. So we're going to make sure that we're working on this as a team, and we're not just throwing a system at you and you're going to have to figure out how to get access for your staff and how to work this around your current system. If you're at all interested in learning more about being an early system user, getting your agency right in at the front line, please contact us at the econsent@hca.wa.gov, and we can set up a one-on-one call with your agency or organization. We're hoping that as people reach out to us to become those early system users, that we can integrate their feedback with some possible calls with the chosen vendor to try and make sure that that final workflow that we put together and any training needs are really being heard from you all in the communities doing this really important work. From here, I think we're going to switch. Oh, sorry, go ahead.
I was just going to say, and I really appreciated the very first, the Menti question on how best I think you would like some of the information presented. And it looked like overwhelmingly, unless I was reading it wrong, it was a webinar. And I think this is something that has worked very well in the past with HCA and our provider partners and organizations. So I think that's something we can definitely accomplish is to have those in place and more of an interactive a webinar sessions, something similar to this as far as future communications, where we're at, your concerns, trainings, and whatnot. So I really appreciate that feedback. Sorry about that, Sam. Go ahead.
No, I was just, I completely agree with you, Kelly. I was just going to transition to the questions that we've been receiving throughout the presentation here. I think we've answered quite a few of them in the chat, but I know one of them is if the solution we're working on, following the consent to share model and model architecture from SAMHSA.
Yes. I'm not sure if anybody else wants to, that was one of the questions in the chat, and yes, that is true. Yes, we are.
Awesome. And then we have another question from Sarah Salmon, I think is how you say it. I missed the organizations that would be included in data sharing. Would people be consenting to share data unilaterally or on a per agency basis?
Yes, and I was just gonna text you back, Sarah, on this. I think I need a little bit more information to answer this correctly. Linda and anybody else, if maybe you have a better take on it, please jump in.
Yeah, actually, the process would work similar to how the client gives consent on paper. They would specify the receiving provider, the receiving recipients, either the organization or the provider specifically, and that would be explicitly noted on the consent. They can do a general designation, but they can, the client determines who receives the data. So it isn't like an all or nothing, like the data goes everywhere. But by default, the client will determine that just as they do now with the paper-based process.
Sarah, I want to make sure that actually answered. If you could either put in the chat or unmute and let us know if that answered your question.
Yeah, I think so. I am newer to some of this. I work for community-based organizations, so I'm not as familiar with what the current paper-based process is. So I don't know if you have any documentation of that you could share so I could get myself up to speed.
Yeah, I think that, I mean, I would ask that you go to the website that was the site that was the link that was pasted. But as far, I think what you're asking for is more something concrete, like what does that look like, right? What is the form or the actual I don't know if it's going to be on a tablet or a paper form or whatnot, what that client actually sees and how they determine who they share their information with. I think that's what you're asking.
Yeah, it was well, that's part of it, I guess. Also just interested in like, who do you like in terms of the types of organizations, who do you envision being part of this data sharing network? Is this restricted to clinical settings for the time being? And yeah, I think that's really more
Yeah,
the part of
that's
it that I was interested
helpful.
in.
That is super helpful. Linda, do you want to answer that one?
Yeah, that's a really good point. We should have mentioned that.
Yeah.
So for the baseline solution, we're thinking that only covered entities, HIPAA covered entities would be using the system. As we get into the expanded solution and the integration with the community information exchange, and there might be some data that would need to be exchanged related to follow up with social services, then we would have to address data exchange between a covered entity and a non-covered entity. But out of the gate, we are thinking providers that are HIPAA covered entities would be the cohort that would be using the system. But that's a really good point. We will definitely update our FAQ on that one.
Yeah, that's a great one.
Thank you. That's really helpful. That's what I was figuring.
And maybe as we move into that expanded solution, we can utilize some of those webinars you guys were, saying that might be really helpful to help drive that work. So that'd be great.
Next question, this is from Mohammed Mari. Not sure if I understood this correctly, but will FHIR act as a facilitator software, enabling the new software to communicate effectively with our legacy system to eliminate any data migration disruption? If so, will there be a testing planned prior to award?
There's a lot going on there, Mohammed. Go ahead, Linda.
So yes, FHIR, we're definitely looking for industry standard interoperability standards, of which FHIR would be one that we're definitely looking at. And we are, as part of the written response and as part of the demonstrations and discussion with the vendors, really getting into what is their testing process. We're not thinking there's going to be data migration, but we are definitely grilling them about their testing and their follow-up and their tracking systems. So, but yes, FHIR is a big part of what we're expecting: cloud-based, industry standard, interoperability standards, that kind of thing.
Thank you, Linda. We have a question from Marcella Marapodi. If the agency has an active EHR, is this an additional cost? At this time, it is not expected that any of the external agencies will have a cost to be using the electronic consent management that HCA will be providing. Hopefully that answers what you're asking.
Yeah, this is Kelly. I just want to add to it. Yeah, no, you're right. I was thinking about the EHR as a service that the state's working on, but I see I read the question wrong. Thanks, Sam. Yep, no additional cost.
And the question came up the other day in another meeting as well about licensing. And the expectation is that HCA will have the license with the vendor, and HCA will provide this solution as a service to the providers. So the individual providers will not be licensing with the vendor. HCA will have the license and will provide it at no cost to the providers. Well, they'll have a license with the vendor and provide it at no cost to the providers.
Thank you, Linda. That's a great addition. I have one more right now, Kelly. How point-to-point consent is going to solve the system data sharing challenges? Wouldn't a general consent for the classes of organizations be more useful?
Deborah, thank you. When a general consent for classes, can you expand on that, or Linda, yeah, go ahead.
Appreciate you taking the question. So the scenario, and maybe this is only relevant for King where we have a lot of providers, but person's getting SUD treatment, maybe they give consents to Harborview, and then the person shows up at Swedish. How is like that kind of point to point consent as opposed to, giving consent for all emergency rooms or all medical providers providing treatment to me, or, all HIPAA covered entities providing treatment to me, or, how would, I'm not sure the point to point really helps.
We have talked with the vendors about that, about allowing a general designation consent and through an HIE, and that they would attest that they have a treating relationship, past, present, or future treating relationship with the client. So there would be some capability for a general designation consent. And that's a really good example of some of the work, the sort of the fine tuning of the workflows as we start working with the vendor. That would be really helpful to have some provider eyes on as we finalize those, because that's a good point. The patients do tend to go to different providers for different situations.
Yeah, thanks. And then I had just one other little, I haven't been working in the behavioral health consent field for a while, but I was curious, what is the status of the integration of this with like CMT and other existing kind of HIE, mechanisms that already provide the SUD consent management?
At this point, we're out of the gate, we're thinking it would be just the consent, and we wouldn't have integrations with those other solutions. With the expanded solution, I think that's entirely possible. Feedback in that regard would be really helpful in terms of, why we should prioritize that for the expanded solution. Because we've had conversations about this. It's like, do we do all of this integration and all of this out of the gate, or do we just get it going and then based on prioritization and feedback from our early users, then build out the solution based on those priorities. So we've decided to go with the latter, but those would be really good ideas for the expanded solution and prioritizing those. If you could send an email to the email alias with describing that a little bit more, that would be really helpful.
Yeah,
Go ahead.
and I wanted to address Becky's question as well. There is a need for mental health providers to be involved in the development. We did, and Linda, maybe you could speak more to this. We did do provider sessions. We did meet with for almost a year. It's been a year or so since we have done it, but we did have, and we did involve our mental health and behavioral health and SUD providers in this. Linda, did you want to expand on that?
On our focus groups?
Yep.
Yeah, and so that was, again, we tried to get it providers from across the different service settings and tried to, that was part of the discussion about, how much do we load this up out of the gate as opposed to doing some of these integrations, down the road with the integrated solution. It is true that, during the pandemic, everybody's gotten a lot more used to doing everything online and doing patient client intake online and scheduling, and more providers have EHRs. So if you've got some specific feedback on that would be helpful to know. And again, feel free to reach out on the email alias, and if you would like to have a one-on-one with HCA to discuss that further, we'd certainly be happy to schedule that.
Absolutely. Yep.
One other point that I wanted to make, I did notice some comments on the concern Menti about security. And that is certainly something that we're very aware of, obviously, and we're really grilling the vendors in terms of their security capabilities. But at the end, what we're making very clear to the vendors, and we've sent them the actual documentation that they would need to fill out, is they would need to pass a rigorous security design review by the state office of the chief information officer, their cybersecurity group. So they, besides being compliant with the regulations and passing the CMS certification process, which has security elements in that, they would also have to pass this very rigorous security design review by the state CIO. So we're definitely have an eye toward that as well, and have been very clear with the vendors about what those expectations would be to conduct all of that analysis.
Thank you, Linda. Kelly, we do have another question that's come in from Becky, and it says each EHR will require build out to interface with this new system. Who will be responsible for this cost?
Kelly, or
Go ahead. Were you going to say something, Linda?
Oh, I was going to say, it would be HCA working with the vendors, the EHR vendor and the solution vendor, because it would be based on the vendor, not each individual provider. So I would imagine there would be that would be the focus. And some of the vendors that we've been talking with have different degrees of experience with that. So I think that the exact process is to be determined, but it would not fall on the individual providers, because it would be with that vendor globally. It would be with that vendor at that provider site.
Thank you. And I'm not super techy here, and I kind of wish we'd had someone maybe from our tech team on this that can answer some of these questions, Becky. But I do know as well is, we have the state HIE and we have the single sign-on. I do know we are looking at that. Like I said, we don't have anybody from there on this call, but provider burden is not something that we want to add to. So we are most definitely taking these. So these are great questions for us to bring back and to noodle with and talk about with our state health information exchange folks and internally. So we appreciate that.
We have some more questions coming in. Can someone explain the client/patient interface with the system? I'm thinking specifically about barriers for marginalized populations.
Sorry, just go ahead.
Oh, Kelly, are you taking that one?
Oh, well, I can. Sure. Sorry, I have to read the question. So again, those types of barriers are being taken into consideration as we look at the different vendors and what they have. I think that it will also, our training, our internal provider and client training groups, I think we'll have to also take that into consideration, like Linda just said. Especially during the era of COVID, things have become I think they're much more electronic and online. So I think that kind of helped push that. But that's definitely something that, HCA and as an agency takes into consideration anytime any new technology functionality is implemented. Linda, did you want to add on?
Yeah, so we're thinking there might be different situations where the consents would be managed One would be the provider, the client in the office with the provider, working with the provider to get into the system and manage the consent. The vendors actually in the ensuing couple of years have made a lot of progress with phone applications. So potentially there's client self-management, either on a phone or at home, for those that would have access to that. But there's also, we're totally thinking that a fair amount of the consents would be managed in the office with the client and the provider together. So if they don't have access to technology or in the office or in whatever the setting is where the provider is interacting with the client on a tablet or something like that, that they would work together to manage the consent. So it wouldn't rely on the client having a lot of access to technology.
Just to add to that, Linda, we've also had conversations during these vendor sessions around being able to upload paper consents for, you know, because there are some areas of the state where it's hard to even get Wi-Fi or web service where some of these clients may be residing. We have been having those conversations as well. And then on the not just electronic barriers for the marginalized populations, we've been very sure to try and make sure that we are very clear that it needs to be very accessible, and we need to have a fourth grade reading level and make sure that everything about it is very intuitive so that you're not needing to have your level of education or experience with medical technology to be able to use the system after it's built. Next question we have coming in is, how are the issues regarding language barriers, non-English speakers going to be addressed?
With the baseline solution, it will be English only. There will, with some of the vendors had capability for more than, for additional languages. Likely out of the gate, it will be English only. There is a way in one of our requirements was that there was some kind of way to document that a translator was used, an interpreter was used during the session if the client is with the provider in some kind of setting and they're assisting with that. But out of the gate is likely to be English only. And I think the next 3 languages that we've identified with our focus group was obviously Spanish, I think Russian and Korean, I think were the next ones. But again, that may have changed if you've got other thoughts in terms of what language should be prioritized. Please let us know with an email to the email alias.
And I don't want to skip over. It looks like Deborah had a question. Is the e-consent vendor solution going to sit on top of provider EHR systems? It will not sit on top of, but be interoperable. That's where that FHIR standard comes into play. So it will not be integrated unless somebody else wants to add on.
That's correct.
Okay. Deborah, I hope that answers.
Thanks for catching that, Kelly. I got lost there in the chat.
Oh, these are great questions. So there's a lot. That's good.
I'm going to give you guys another second in case you have any more questions for us. I did want to, let you guys know that this information is really helpful to us. When we say please email us on our dedicated email, that we really mean it. We take everything you say to heart. This is a system that everyone on the team here is really dedicated to trying to make work for you guys rather than more work for you. So please send us your suggestions, your questions, your comments. It really helps make the system better. and is really important to us. Okay, we got another question from Tara. Is there any future discussion about interstate consents and usage?
About what?
Interstate, like, and she goes on, we have many folks who go back and forth, like our border cities,
Mhm.
Oregon and Washington, for example. I think, you know, for this initial, right, this is Medicaid. So Tara, to answer your questions, we have, I believe those that are border would be included in this initial rollout. Hopefully that answers your question. Now, if they went to Florida, I'm not so sure. But yeah, at least for our border cities, and they are currently Washington. It's Washington Medicaid providers and clients. And then Shirley looks like.
Yes, consents for adolescents who can consent to mental health treatment, but not medical treatment. Will those be separate? Also asked, would there be multiple consents to pick from, for example, SUD, mental health, physical?
These would be separate from medical consents for procedures and that kind of thing. Yes, and then the vendors handle it a little bit differently. It seems like most would have a separate consent for the HIV data, the SUD data, and different kinds, just because there's some different data elements involved, et cetera, but they handle it slightly differently. So again, this would be a really good topic for some of those final workflow discussions and design discussions with the vendor once we get going with them.
And the other part of your question, Shirley, about adolescents who can consent to mental health but not medical, then also ensuring throughout that the vendors are very aware of that, and talking to them about how they would navigate that age up to be able to consent or not consent for mental health treatment when that happens and things of that nature.
So this isn't this isn't being used as a consent. I mean, it could later on, like Linda said, right? A consent to maybe a treat. This is a consent to share your information that is currently not shareable currently. And someone else brought that up too. There's been a proposed change to the rule, but it is not currently shareable under HIPAA. But surely these are the types of for the expanded solution, or healthcare authority is working on other initiatives like Jennifer had touched on earlier. Advanced directives is one of them, and I see this more fitting into that sphere. But Linda, were you going to say something?
No.
Okay. And just to reiterate what Sam said, we are not the professionals. We're not the ones that are having to do these consents or with the populations, and we don't know, so we really rely on your expertise and your questions and to really make us think about those things. So we just can't tell you how much we appreciate this, and we definitely need to have this again, and we'll be sure to get that on the books, because this is very helpful.
Elliot, I am not seeing any more questions come in. So I'm going to go on and I'll talk about our next steps. So we're going to be announcing our apparent successful bidder and completing procurement here in the next couple months. Our bidder should be coming out early February. And then as explained by Linda, there's a little bit of a back and forth on the contract and getting the contract to CMS and all that with a hopeful start the building happening early spring. I guess that might be mid-spring, May. Also, we are monitoring updates to 42 CFR Part 2, and our vendors they also have been with those changes. So there's not going to be any big surprises for them. So we will let you guys know if we see anything big, and definitely reach out if there's some big changes that are happening to see how those are affecting you at the practice level to make sure that we address those in the system. We are going to take all these questions. We've been tracking them this whole time externally, or an Excel document to make sure that we are able to update that FAQ and have these accessible to you all. Those will be on our webpage linked here that was dropped in the chat earlier. And as well as that FAQ, we'll also have the recording of this meeting and a PDF version of the slide deck up there by the 14th as well. And then finally, we are just really going to be continuing to do this partner stakeholder provider engagement, because as we've talked about, it is really important to us, and we don't know everything, and we know that. And so we want to make sure that we're creating something that will be useful and utilized by you all. So Kelly, Linda, is there anything else that you'd like to add before we close the meeting today?
Nope.
I just hope this was useful. Please let us know in the chat or otherwise send us an email if this was useful. If you know, to continue on with these, if there's, I know we did the Menti, but if there's anything additional that we can do to make sure that you guys heard and you have a voice during this, we'd really appreciate it. And thank you again. Thank you so much for taking the time out of your day.
A lot of feedback in the chat that this was useful, and we should continue to do them. So that's really great to see and to hear. So I hope that you all have a wonderful day and that you have a good weekend. We're almost there. Oh yeah, thank you, everybody.
Thank you.